Okay, good morning everyone. So today I'll be discussing a fairly new technique that was introduced in the CathLabs. So for the moment, only a couple of our EP cardiologists perform this technique, Dr. Anthony Chow and Mihal Dinoja. So my objective for this teaching is that in the future, if you're gonna encounter this case, at least you know the theory behind the procedure, how it is being done, the equipment needed, and you'll be mentally and physically prepared. So just a very quick, brief, history of recap of the layers of the heart. So you have 3 layers of the heart: the endocardium, myocardium, and the epicardium. And the heart sits in a fluid-filled sac called the pericardial cavity. So 15% of idiopathic VTs originate in the epicardial layer. So how would you access the epicardial layer for ablation? So you would have to go through the pericardial cavity. So what is the most common technique that you can access into the pericardial cavity? Any ideas?
The groin.
Pericardial cavity? Through the groin? Okay. Very good. So it's called subxiphoid pericardial puncture. So basically this technique is a blind puncture because X-ray doesn't really give you much idea where the pericardial cavity is. And as you can appreciate in this photo, there's a very small margin between the pericardial layer and your right ventricle. So it is very highly likely that you can puncture your RV. Actually, it's 15% of the complications is because of RV puncture. And here in this photo, it's basically you just need to know the anatomy of your patient. So 30 to 45 degrees, pointing your needle left mid-clavicular point, that's it. So it's basically a blind puncture. So what coronary venous perforation with subsequent pericardial carbon dioxide insufflation would do is that you would access the cardiac veins. So these are your cardiac veins. Sorry for the picture, I just edited it. So you would basically puncture a cardiac vein, exit it, and then access into the pericardial cavity in order for you to inject the carbon dioxide. And this is to assist the subxiphoid pericardial puncture in the setting of epicardial mapping and ablation for VT. So the technique requires that coronary venous perforation would not lead to significant bleeding. So the key aspect for this is that you would have to select a cardiac vein, which is a very small cardiac vein. So the smaller the vein, the lesser significant bleeding that it would cause post-procedure. So I'll show you a X-ray acquisition. So this is what it does. So basically you will enlarge the pericardial space with the CO2, and that's your spinal needle there. And CO2 is a very good negative contrast agent. So see, it will guide your wire where your pericardial cavity is. And your right ventricle is very far from your spinal needle. I'll just replay it so that you'll appreciate it. Here, that's your spinal needle, and that's your right ventricle. So you're basically enlarging the space and making it visible in X-ray.
Could you now tell me under contrast?
Yeah, so
Are they using carbon dioxide instead of contrast?
no, so only carbon dioxide because contrast will just leak through the needle.
Sometimes they use contrast if they're not using the CO2.
Yeah, so see, contrast is mainly just to confirm their position, but not for the puncture. So the indications for the technique is mainly to reduce the complication rates. So again, the overall complication rate is 25% in total, and right ventricular puncture rate is the highest in the reported cases. Other causes can be abdominal viscera and coronary vessel damage. If you can see, if you can puncture very low, you can puncture the diaphragm and your abdomen. And this technique can also be used for patients who had prior failed epicardial access VT and those who had previous cardiac surgery, because they would have pericardial adhesion, so the epicardial puncture would then be difficult. So why CO2? Any ideas?
Denser. Because it's not oxygen.
Oh, very good. It is. So it's denser. So as a lot of reasons. So it's a good contrast agent, and it's inexpensive. It is highly soluble, which means it can easily be eliminated in your body via the lungs. It has a low viscosity, very good Kim, which means that it can flow easily around a cavity or a space and allows injection via small needles and catheters. And it is buoyant, so the lesser density means it is easily eliminated in the body. So the equipment that you will need is that first you would need the EP pack and the pericardial drain kit. The reason why I included the pericardial drain kit is that after the epicardial VT, you would need a drain overnight anyway, so it's better to just open a drain kit. So for those of you who don't know the pericardial kit in EP, it's an 8 French compared to the intervention, which is 6 French. A Gillis catheter is used to cannulate the CS. So again, this is operator preference, medium or large curl. A Gillis catheter, and a JR4 catheter is used to subselect a vein, as if you don't know what it looks like. And microcatheters. So you have a choice between a microcatheter and an over-the-wire balloon. So it's either a microcatheter or over-the-wire balloon that will deliver the CO2 into the pericardial space. So any idea, any examples of microcatheters that you know? Fine cross, very good, fine cross. What else?
Corsair.
Corsair, very good. What else? Huh? Caravel, yes. And you can also use a Turnpike LP, or yeah, it is expensive. Or Turnpike Gold. And over the wire balloons, we have Reurgin Plus. It's the smallest that you can possibly offer. Fun fact.
The region, the name came from? It's the Japanese word for
Dragon.
water dragon.
Wow. Okay, thank you, Rodney. So actually, the over-the-wire balloon is only to deliver the CO2, so you don't need to inflate the balloon. Okay, so it's either a microcatheter, you have a choice, a microcatheter or over-the-wire balloon.
Why over the wire, man?
So it's you can put the wire exactly. You can put the wire through, and it's 0.18 anyway. So that when you puncture or perforate the vein, it's a very small puncture. Okay. And a heavy tip load wire. So tip load refers to the stiffness of the wire. The higher the tip load, the stiffer the wire is. So any examples of a high tip load wire? Angioplasty wire?
To those who do
CTO.
As tattoo?
Yes, you have Hornet. What else? Charmaine, you do CTO.
Yes.
I said Hornet already.
Yes, Hornet. Very good.
Confianza.
Yes, Confianza. You have a Confianza Pro 12. Confianza Pro 12 and Hornet 14. So Hornet is stiffer than the Confianza 12. Of course.
The number.
Sorry.
The number corresponds to.
The tip load.
Yeah.
So the number corresponds to the tip
So the
load.
higher the tip load,
The stiffer it is. Yeah. So that the wire is used to puncture the cardiac vein. So you can also use a normal angioplasty wire like a cyan blue, but they use the back end of it. Yeah, not the J-tip. Yeah. Mehul used it before, cyan blue, and then you just used the back end. Yeah. And the insufflation tubing. So we have a sterile insufflation tubing here. So if you can pass it around. And the CO2 cylinder just here at the back.
Where do you store it in the
So it's all stored in the EP storeroom, and they're just next to each other. So this is an opened insufflation kit. So you would need the green extension tubing for your oxygen, a 3-way tap, and a 50 ml Luerlock syringe. So I'll explain how it is being used.
The green tubing,
So-
Katreena, is unsterile.
Yes, so basically, how you set it up, so that's sterile, no? And then this will come out as this. Yeah. So you would just, so this will come out as sterile. So you will just remove this tip and then connect it to the green. And then the other end will be connected through a 3-way tap. And then the side port will be the 50 ml syringe.
So the other end, Katreena, the first one is unsterile.
Yeah.
Yeah. So you will, so as a scrub nurse, you will give this end to the circulating nurse. Can you see it, Olivia? Yeah. And this other end will then be connected to the JR4. That's sterile now. So starting from here, this will be sterile. Okay?
Oh.
So slowly,
So just slowly.
1 liter lang siguro. Inject.
So they will inject up to 150 ml of CO2.
Sige go. 1 liter.
So don't yank it up to 10 liters. Yeah.
Ito so 1 liter lang. 1 liter lang siguro.
Sorry?
When it goes into the cavity, is it a bit like a tamponade, or if you think of it?
Yes, yeah.
So you have to look at your patient.
So we should like put a marker.
Yeah, basically.
Not more than one.
But it won't affect the contraction of the heart.
Okay.
Yeah, so it's like tamponade like, but it won't your patient won't arrest.
That's because it's for to do with it's CO2.
Yeah. Yeah. Okay, so extra CO2 cylinders, they're kept behind lab 1, okay, just for your information. Which one of this is the CO2 cylinder?
the green one.
Very. Please make sure you get the correct CO2.
Well, I don't know how to change the kanang gauge.
So I don't know either, but the ODPs know. Just yes. So this is now the step-by-step method. So you will have a dual access in the right femoral vein, an 8 French sheath that will be used for the Agilis catheter, and a 4 French for just arterial monitoring. So the medium or the large curl Agilis will be used to cannulate the coronary sinus, and then you will use CS venography using contrast injection. So this is how it would look like in X-ray. So that's your Agilis catheter there, and these are your cardiac veins, and you would select which cardiac vein you would use. So again, the most important thing is to select the smallest vein, so that lesser significant bleeding at the end of the procedure. So in this case, a lateral CS branch or an anterolateral branch is selected using a 5 French or 6 French JR4. It's used to subselect the target venous branch. And then through the JR4 will be your high-tip load angioplasty wire. So that's your Agilis catheter, that's your diagnostic catheter, and through that is the angioplasty wire. Do you get it? So they're using the anterolateral CS branch in this case. So actually they have punctured already into the cardiac vein. So their wire is already around the loop. I'll show you an acquisition. So this one. So this is a magnified view. That's your wire going out and around the pericardial cavity. Can you appreciate it? Not really. I'll play it again. JR4 guide, wire will come out there.
Ah, okay.
See? And then it punctures and then going around the pericardial cavity. So once the wire is seen around the loop, the wire balloon and the microcatheter will then be passed over the wire and into the pericardial space. So again, the angioplasty wire should go through the pericardial cavity very easily, but if not, they'll confirm with contrast injection for their pericardial positioning. So you can these are other examples of different cardiac veins that you can use. In here, this is the anterolateral vein. This is the posterolateral vein that they used. And if you are gonna ask, you can use a vein that has an LV lead, CS lead. So it is not recommended to use this vein because highly likely that you will displace the pacing lead, ventricular pacing lead. But in case, it can be used. And next, the CO2 tank will then be connected via the sterile tubing, as I have showed you a while ago, into the 50 ml Luer-Lock syringe, and up to 150 ml of pure filtered CO2 will then be injected through the microcatheter using handheld syringe method into the pericardial space and observing it via X-ray. So this is the setup again, sorry. And that's how it should look like in X-ray. So that's your pericardial space with the CO2 insufflation. So once the sufficient space is visible, the pericardium is then punctured using a Toei needle. And then after tenting of the needle can be visualized, the pericardial space will then be entered via with the 150 cm J-tip wire. Yes? And then the Toei needle will then be removed and then you will be left with the wire, and it will facilitate the entry of your Agilis sheath. And then through the Agilis sheath will then be your ablation catheter. So for those of you who don't know, there's an epicardial Agilis catheter. It is shorter than your femoral Agilis catheter. It's 61 centimeters. Yeah, it would say EPI here, epicardial. EPI. I think it's EPI. I think it's just 51 or 41. This is 61 centimeters. So really, your cardiac vein access is just so that you can introduce the CO2 into the pericardial space. But you will still use the subxiphoid puncture, but then it will be lesser complications because you'll basically enlarge the space. Yeah, and you know where your needle is going. And then aspiration will be undertaken to remove CO2 and any blood before the ablation. And then the microcatheter and over-the-wire balloon will then be withdrawn after the successful epicardial access. And your Agilis sheath, which was in the coronary sinus, it can either be used for RV endocardial mapping or it can be removed if not needed. So at the end of the VT ablation, your consultant will ask you to prepare antibiotics, so gentamicin or Fluclox, and they will administer it directly into the pericardial space. So Dr. Chow only uses gentamicin, but I don't know with Dr. Dinoja. I haven't tried. And this is to reduce the risk of pericarditis and subsequent pericardial adhesion formation after the procedure. A pericardial drain will be left overnight, and protamine we will use to reverse the heparin, and transthoracic echo will be done post-procedure. So this is not the transthoracic echo that you would like to see after the procedure. So this is pericardial effusion, for those of you who don't know. That's cardiac tamponade actually. So the limitations of this technique is that only few operators for the moment perform this. So only 2 of them in the department. But they're encouraging more consultants to perform this procedure, which the overriding goal is to perform epicardial puncture safely. So it adds 15 minutes to the procedure and requires an extra technical step. Fairly new technique, and pericardial adhesions can be encountered during the procedure. So for patients who had previous cardiac surgery or those who have history of pericarditis before, pericardial adhesions can be a contraindication for this. So your wire should go through smoothly through the pericardial space, but if it holds up or it buckles, that's the time that they inject contrast. So as you can see here, this is called a dye hold up, and it has a disc shape. So that's a pericardial adhesion there. So the wire can't go through. So I've encountered this procedure, or like I've encountered this before. I've encountered this case before, and we've abandoned the case. So the patient had previous prior failed epicardial puncture already. So the endpoint for this is that coronary vein exit and subsequent percutaneous subxiphoid pericardial access after CO2 insufflation can be achieved reliably and safely. So for the moment, we don't do this routinely for epicardial access, but Dr. Chow said they do it routinely in Brighton now. So if this can be used as often now, then we can do this routinely, and it can be the first line method for epicardial VT ablation. Any questions? Thank you for coming. Thank you.